So, dear Professor Rector Merkeli, dear Professor Widimský, dear colleagues, dear guests, I am delighted to have the opportunity to open this unique event, and I would like first to ask Professor Béla Merkeli, the Rector of Semmelweis University, to deliver his opening speech.
Ladies and gentlemen, honored guest, dear Professor Widimský, please allow me to warmly welcome you on the occasion of the Semmelweis Budapest Award scientific meeting and awarding ceremony. I am delighted to be here with you today. With an almost 250-year-old tradition of academic excellence, Semmelweis University is widely recognized as one of Europe's leading centers of medicine and health sciences, combining innovation and tradition in three main areas: education, research, and healthcare. However, in addition to this triadic priority system, we also take pride in recognizing extraordinary achievements to promote science and show guiding example to younger generation and experienced researchers alike. With this objective in mind, the Senate of Semmelweis University established the Semmelweis Budapest Award in 2009, an award that is our institution's highest attainable international scientific honor. The award recognizes the achievement of world-renowned and accepted international researchers working in the field of natural sciences, whose research activities have produced internationally acknowledged results and whose work contributes significantly to our understanding of living natural science and to benefit to humankind. There is no need to say all the candidates had to show a very strong devotion to Semmelweis University, which can be reflected in intensive scientific collaboration and other living connection and relationships. 7 exemplary scientists have been presented the award since its establishment. At first, in 2010, Professor Jeremy Nicholson was awarded in recognition of his groundbreaking work in metabonomics, which has contributed significantly to the development of new diagnostic methods. In 2011, the university's highest scientific honor was bestowed upon Professor Sir George Rada, the Hungarian-born father of magnetic resonance imaging examination, as well as remarkable fellow of international science policy. 5 years ago, Professor Péter Somogy, another famous scientist of Hungarian origin, received the award recognizing his pioneering research efforts of the chemical identification of neuronal types and the localization of signaling molecules in identified microcircuits. It was in 2013 when we awarded Professor George Olah, the Nobel laureate chemist, who had started his career in Budapest at the medical university. He was developed a promising new approach to solving not only our long-range dependence on decreasing fossil fuels such as oil, gas and coal, but also to mitigating global climate change caused significantly by greenhouse gases like carbon dioxide and methane. Another year has passed. In 2014, the Semmelweis Budapest Award went to Professor George Klein, who was not only world famous for his outstanding cancer research, but also for his essays and unforgettable thoughts on the theory of science. His books have been translated into Hungarian and are among the bestseller works depicting the problem of present-day science. We are very proud that he was also one of the famous Hungarian-born scientists who has got the opportunity to influence world science questions. It is extremely sad that these two wonderful personalities, Professor George Olah and Professor George Klein, are not among us anymore. In 2017, they have passed away in Stockholm and in Los Angeles, respectively. It is our great respect that the remains of Professor Olah have been buried in Budapest. Professor Thomas Högfeldt, his lifelong achievement in chemical neuroanatomy are worthy of any prize. It is a great honor for Semmelweis University, as well as for us personally, that we could confer these awards on Professor Thomas Högfeldt 2 years ago, and we were all amazed at his modesty and wisdom, and he came out with his groundbreaking results in neuroanatomy. In 2016, the recipient of the award was Professor Stefan W. Hell, the world-leading scientist in nanoscopy and high-resolution biomedical imaging. He was the recipient of the 2014 Nobel Prize in Chemistry for his work in which the inherent optical microscopy resolution limit was surpassed by the use of fluorescent molecules and the spatial illumination technique he developed. Last year, our awardee was Sir Ravinder Maini, Emeritus Professor of Rheumatology at Imperial College London and visiting professor at Oxford University. Professor Maini's professional activities are linked with several ties to Budapest and the Hungarian scientist scene. The Kennedy Institute of Rheumatology, previously led by Professor Maini, has been providing scholarships to many Hungarian researchers, enabling Hungarian medical community to get a first-hand opportunity to learn about new therapeutic options in treating inflammatory diseases. Today, the list of the awardees grows once more, and Semmelweis Budapest Award's prestige, importance, and relevance increase on this spirit-lifting occasion. It is my great honor, pride, and pleasure to announce that the 2018 award goes to someone who has been awarded the highest national and international scientific recognition that exists, Professor Petr Widimský. Now I would like to ask Professor Péter Ferdinandi, Vice Rector for Science and Innovation, to deliver Professor Widimský laudation. Thank you very much.
So before giving the floor to Professor Widimský, I would like to introduce his career and scientific achievements. Professor Widimský graduated at the Charles University Prague in 1979. He earned board certifications from internal medicine in 1987 and from cardiology in 1992. Since 1979, He has been working in the University Hospital Královské Vinohrady in Prague as a research fellow, resident, assistant professor, associated professor since 1991, and a full professor since 1998. In between 2000 and 2003, he was the vice rector of the Charles University Prague. Since 2010, he has been vice dean for research at the Third Faculty of Medicine, Charles University Prague. Currently, he is the head of the Cardio Center at University Hospital Královské Vinohrady, which he founded, as well as chair of the Cardiology department at the Third Faculty of Medicine at Charles University and University Hospital in Prague. He has completed more than 5,000 PCI, percutaneous coronary interventions procedures, and twice as many coronary angiograms. Since 1997, he is the leader and main author of the multicentric randomized national studies called Prac, presented 13 times at prestigious sessions like the hotline late-breaking sessions of major cardiology congresses. Currently, studies up to Prac 21 are running. Professor Widimský served as the president of the Czech Society of Cardiology from 2011 to 2015. During the term of his presidency at the Czech Society of Cardiology, the society was awarded by the World Health Organization Prize in Geneva. Currently, he is vice president of the Czech Society. Since 2005, Professor Widimský has been chairman of the National Board of Accreditation in Cardiology at the Czech Ministry of Health. He has published more than 5,000 manuscripts, including 350 which have been appeared in PubMed. He is also an author of 20 textbooks and chapters within textbooks for teaching and also research. His citation is close to 38,000. His Hirsch index is 63. He has served on the editorial boards of the European Heart Journal and Cor et Vasa, among other journals. In 2011, Professor Petr Widimský received the most prestigious research award of the Czech Republic, the so-called Czech Head 2011. Besides, in 2014, at the Congress of the European Society of Cardiology in Barcelona, he also received the European Cardiac Society Gold Medal in recognition of his outstanding achievement in cardiology. Since 2015, he has been recognized by Thomson Reuters as the most cited Czech physician every year, and has been listed among the best scientists in the world. In 2016, he has awarded the prestigious Mensa honorary recognition for the substantial contribution to the intellectual level of the Czech nation and propagating the country across the world. In 2017, he received the Charles University's prize, the Donatio Universitatis Carolinae. Professor Petr Widimský has been collaborating with Hungarian colleagues and centers for several decades. He involved in Hungarian institutions in his world-known milestone study, the Prague study, and the Stand for Life initiative as well. He is a regular lecturer at Hungarian conferences, and he is also the honorary member of the Hungarian Society of Cardiology since 2017. This was, ladies and gentlemen, a short summary of the scientific activities of Professor Petr Widimský. As such an introduction, it is needless to say that the University Senate accepted the proposal of Professor Widimský to Semmelweis Budapest Award anonymously. The scientific achievements of Professor Petr Widimský show to all of us how an outstanding clinician researcher can move the world forward. And now I would like to ask Professor Widimský to give his presentation entitled The Prague Trial Story, from Myocardial Infarction to Ischemic Stroke. Please.
Your Magnificence Rector, Your Magnificence Vice Rector, dear colleagues, ladies and gentlemen. First of all, I would like to thank to the Semmelweis University and personally to Rector Professor Merkelly for inviting me to Budapest for this occasion and for proposing me for this prestigious extraordinary award. I have the task now to share with you the experience which we have in the Charles University in Prague with a series of trials which have acronym Prac. We selected this acronym Prague trials not only because it is the name of our capital city and because we are working in that city, but also because it's the first Prague trial. It was an acronym and it was abbreviation of primary angioplasty for patients transferred from general hospitals to catheterization units with or without emergency thrombolysis. So it was an acronym, and also it is the name of our town. On the first slide, I inserted two pictures, one of Prague and one of Budapest, because historically we were around 300 years together in one country, and we still share very similar views on many problems. Allow me with few slides to show you some historical introduction. I will go a little bit further, then I can see better to the slides. The Czech Society of Cardiology is proud that it is the third society of cardiology and was founded in 1929. And we are also proud that in our country and in Prague, this man was working, and his name is Otto Klein. And Otto Klein was the world first physician who introduced catheters into patients' hearts. And more cited is Werner Forssmann, but Werner Forssmann introduced catheter to his own heart, but Otto Klein introduced catheters to hearts of 11 patients. So he was the first doing diagnostic cardiac catheterization, and he measured successfully in these 11 patients cardiac output by the FIC method. And this is the paper he published in München Medizinische Wochenschrift. Another important figure in this relation, this is more now focused to my hospital where I'm working, was Professor Mentel, who was head of University Hospital Department of Cardiology. And basically this was the first Department of Cardiology which was independent from internal medicine, and it was founded in 1935. And the second cardiology department in our country was founded only 20 years later. Then in our hospital, we started with interventional cardiology in 1981, and in 1995 the cardiac surgery started, and in 1996 the first Prague trial was planned and started, as I will show you in a minute. This is a historical slide showing the first patient from 1982, and this was the first case we treated by intracoronary thrombolysis successfully. And this is the patient ECG after 24 years. And this is the same patient left ventriculography 24 years after treatment, and his coronary arteries 24 years later. So this is an example of successful intervention for acute myocardial infarction, albeit this was intracoronary thrombolysis, which was later abandoned. We were involved in acute myocardial infarction since those years, and this is a paper from 1985 when we followed the improvement of heart muscle function after opening the artery by intracoronary thrombolysis. And for my professional career, very important period was between 1990 and 93, when I was 2.5 years working in the Netherlands. And on the picture there is Professor Surya Pranata, who was working originally in the Thorax Center in Rotterdam, and then he moved to Zwolle, and I was working with him in both these departments, and he influenced my enthusiasm to clinical research very much. This is a picture showing one of our first patients. We started with primary angioplasty service for our patients after when I came back from the Netherlands, so it was late 1993. So this is one of our first patients who was treated for STEMI in 1994, and 1 year later he successfully trekked in Himalayas and made it up to 5,500 meters. And this, we are now coming to the story how Prac 1 study started. This slide shows the mortality of myocardial infarction patients in our hospital in 1994 versus 1996. And in 1995 we switched from thrombolysis to primary angioplasty. And you see immediately the drop in mortality. So when we have seen this drop in mortality, we are thinking how to offer this modern treatment to more patients, not only to those who are living around our hospital. So then we did, this is a small study done with our students to map the mortality for myocardial infarction in those years, 1995, in different types of hospitals. And you see, small hospitals, mortality 29%. Moderate-sized hospitals without cath lab, mortality around 17%. And PCI centers, mortality around 7% because of primary angioplasty was done in that time in those hospitals. This was done in 11 different hospitals in the Czech Republic. So it again pushed us to the thinking how to offer this to more patients in the country. And then we started the Prac 1 trial. Just one or two slides to give you an idea about all the Prac trials. This is from a paper published in European Heart Journal 2 years ago, I think. And this is the full list of Prac studies. Of course, I will not go through all of them. They are now, the last study which started 2 weeks ago is Prac 23. I will go with you through my speech. I will go only through few of them whom I consider most interesting or most important. And this slide shows the group of key investigators of the Prac trials in Aula Magna in our university in Prague. Prac 1 study, one is in parentheses because when we started this first study, we didn't know that other studies will follow. So officially there was no one number. It was called only Prac study. And the study was randomizing patients with acute STEMI to thrombolytic treatment or to primary angioplasty. This is another case of myocardial infarction with ST elevation, right coronary artery occluded, and after stenting. And when we were planning this study, we were facing some difficulties because in mid-90s, the idea to transport patients with acute myocardial infarction for a long distance, it was up to 100 kilometers distance. So this idea was considered to be crazy. Because in those years, everybody with myocardial infarction should be moved to the nearest hospital and put in bed and couldn't move. So we faced some resistance from some conservative colleagues, but also from the official institutions. And we applied for the grant for that project, but the grant was rejected. And furthermore, I was called to the board of the health ministry to explain why I'm so crazy and willing to kill the patients by transferring them. So that was quite a difficult time, but fortunately, there was full support from the board of the Czech Society of Cardiology, and with this full backup from my colleagues and friends, we were finally allowed to do the study, albeit without the financial support. So then we succeeded to complete the first study on 300 patients, randomized in 17 primary hospitals and transferred to 4 angioplasty centers. So altogether, the study was performed in 21 Czech hospitals and published in European Heart Journal in 2000. And these are the groups. Patients were randomized to receiving thrombolysis in the nearest hospital and staying there, or receiving thrombolysis in the nearest hospital and transferring to angioplasty center, or no thrombolysis and direct transport for primary angioplasty. And these are the time intervals. So you see that, of course, the patients who received transfers, the time to opening the artery was slightly longer, but the difference was not so great. It was about 30 minutes. But of course, you should realize that with thrombolysis, you can open the artery only for about 50% of cases, not more. And with angioplasty, you open the artery with more than 90% of cases. And this is the flow. What we expected, actually, if I go back to this slide, when we planned the study, we expected that this group will be the best one. That when we give thrombolysis in the nearest hospital and patient will go with thrombolysis to the angioplasty center, that this will be the best combination. However, this is what we have observed concerning the flow. So there was slightly more open arteries with streptokinase during transport, but the difference is not so great. 27% opened arteries only after heparin and aspirin. And then after angioplasty, of course, the figures look similarly, but the key finding is this, and this is clear separation of the Kaplan-Meier curves on the primary endpoint, which was death, recurrent infarction, and stroke. And this is up to day 30. And you see that the group with primary angioplasty had 8% incidence, the group with combination had 15%, and the group with thrombolysis only had 23%. So to our surprise, the primary angioplasty strategy was the best one. And this slide shows you why. This slide shows you why the group B, with combined strategy, was not the best one and was inferior to primary angioplasty strategy. This is fatal bleeding or cardiac tamponade, only in group B. So the Prac study one conclusions were that transferring patients from community hospitals to angioplasty centers up to distance of 100 kilometers is feasible and safe, and furthermore, it offers better outcomes to the patients. Similarly, or almost simultaneously with Prac study, we were running a study called VINO. It's also abbreviation. And VINO study randomized patients with small infarcts, with so-called non-ST segment elevation myocardial infarcts, and randomized them between primary angioplasty-like strategy, so very aggressive strategy with immediate catheterization, or very conservative strategy with catheterizing them only when there was ongoing ischemia or recurrent pain. And with this difference, with very aggressive and very conservative, we observed a major difference and, of course, benefit for the invasive strategy in the VINO study. And this is the graph showing the outcomes of these patients at 30 days and at 6 months, favoring very clearly invasive strategy. And even in this VINO study, it was a small study, but the difference favoring the invasive strategy was even bigger than in the Prac study. After Prac 1 study, and also after VINO study, but mainly after Prac 1, we were discussing on the national level whether these results, based on 300 patients, are enough, are sufficient for change of strategy in the whole country. And then the discussion ended that it is too early and we have to support it more. So then we planned Prac 2 study, which was planned on 850 patients and was completed in 51 Czech hospitals. This is the map of the country. So you see that the cooperating hospitals were covering almost half of the country, and the red dots are small hospitals which were referring the patients, and the blue dots are angioplasty centers. There were 7 angioplasty centers. And the results were confirming the results of Prague 1 study. And because this was the second study confirming the results, because the results again confirmed that primary angioplasty is the best strategy, and also because simultaneously there was a Danish study called Dynami trial. So it was then accepted that primary angioplasty should be the strategy of choice. Czech Society of Cardiology is very proud that we were the first scientific society worldwide who implemented this into official guidelines. So we published our guidelines in Corret Vasa in 2002, and you see that primary angioplasty was recommended to most patients with ST elevation myocardial infarction, with only one exception, and this is patients with long transfer to PCI and very early presentation. And 1 year after, Czech Society, the European Society, accepted similar recommendations, and Americans were 2 years later. And this is how the network of angioplasty centers developed in the country after Prague 1 and Prague 2 studies. So you see now that the country is covered. All these red circles are angioplasty centers, and if you look for distances, so longest distance is here, and it's like 150 kilometers. So from this village, the distance to angioplasty is about 75 kilometers, so about 1 hour transfer time, let's say. And this is very important because this looks how these clinical study results transferred into routine practice and into outcome of patients. These are data from the registry from 1999, and these are data from 2005. So this is before the change of strategy in the country, and this is after the change of strategy in the country. And the green color means mortality for infarct, mortality due to STEMI in PCI centers, and the red color means mortality of infarcts in non-PCI hospitals, so in smaller hospitals. And you see here the big difference, and it completely disappeared. Of course, because all these patients were also transferred. So this was the story of the first 2 Prague studies, which, of course, triggered a lot of enthusiasm between all co-workers. As I said, there were 51 Czech hospitals participating. So we built a nice infrastructure and a lot of enthusiasm to work together. And then we decided to cooperate and to investigate other clinical questions or uncertainties with additional studies. Prague 4 study, for instance, was a study done in cardiac surgery and was a randomized study comparing off-pump and on-pump surgery. So it was one of the first trials randomizing cardiac surgery patients to beating heart surgery versus classical on-pump surgery. And it showed that off-pump surgery is feasible and offers slightly better outcomes, especially in high-risk surgical patients. Prague 8 study was a study testing the strategy of pretreatment of patients before PCI. This was a study done in stable angina patients or stabilized unstable angina. And in that time, when the study was planned, the recommendation in the guidelines was that every patient before coronary angiography should receive pretreatment with clopidogrel. And we were never using this because we considered this is nonsense. So then we decided to test the 2 things, guidelines versus our routine, in a randomized way. So that was the Prague 8 trial, which was published in European Heart Journal 2008. And these are the data from the trial. And the trial showed that really to give clopidogrel pretreatment to everybody before every coronary angiography is nonsense. And this was confirmed later also by the largest study from France done by Gilles Montalesco. So these were the conclusions which I already commented. Another interesting study is Prague 12 study. Prague 12 study was focused, it was again cardiac surgery study. And the story is interesting because the chief of our cardiac surgery was my very good friend, Professor Zbigniew Straka. we were friends for more than 20 years, and we had very nice interaction between each other, and a lot of stimuli came out from our discussions. And when we indicated our daily patients for cardiac surgery, he always said, I want to do MACE procedure in these patients, so I want to do ablation for atrial fibrillation. And I always said, I think it is nonsense. I think it is not useful and it doesn't help to the patient. So this was kind of discussion we had a couple of years, and then we decided to randomize the patients and to decide who is right. And I must say he was right. And this was the Prac 12 study. Prac 15 study was a study done in patients with hypertension. That was done a couple of years ago when there was the initial enthusiasm to renal denervation treatment. And we had a lot of discussions whether catheter-based renal artery denervation is something useful or not. So then we decided to make this Prac 15 study, and it was one of the first 3 studies randomizing these patients to best medical treatment or radiofrequency ablation of renal artery plus medical treatment. And the study ended with a neutral result, or in fact slightly better result even for the conservative group. So as a result of this Prac 15 study, we completely stopped renal denervation in our hospital. Prac 16 study has started in 2012, in October 2012, and this basically means that we entered a new area. We entered the area of acute ischemic stroke. And why we started to be involved in acute ischemic stroke? This is Václav Chalupka, who is my good friend for many years, and he was, before my term, he was the president of Czech Society of Cardiology. And while being president of Czech Society of Cardiology and head of department in a big university hospital in Brno, he suffered ischemic stroke. He was not treated adequately, and he is, since that time, he is in a long-term facility, hospitalized and severely disabled. So it is a very sad case demonstrating that in 2010, the treatment of stroke in the country was horrible. And then we decided to start to think about it, and in my hospital, there were no interventional radiologists, so we agreed with our neurologists and with our radiologists that we shall start interventions in cardiology department. So we treated the first stroke with thrombectomy. This is the thrombectomy device. And we started, this is another thrombectomy device, and this kind of clots we are retrieving from the cerebral arteries during these procedures. And we started as I said, in October 2012. And this was our first case. This was a 45-year-old mother of 3 kids who had a stroke probably triggered by contraception. She had no other risk factors. She was only using contraception. And she came in with severe somnolence, hemiplegia, aphasia, and this was the cause, occlusion of middle cerebral artery. And after, here is not so well seen, the stent in position, the stent retriever, and here is the open artery after removal of the clot. And what was very stimulating to the whole team of our department, that this lady opened eyes and started to speak within minutes after clot removal. So still while she was in the catheterization laboratory on the table, she suddenly opened eyes and said, "Oh, sorry, I'm feeling cold." You can imagine how lucky we have been to listen that she's speaking again. And 2 hours later, which this picture was taken 2 hours later, she was asking us whether she can go home. So she was completely well after 2 hours after major stroke. She was asking whether she can go home. We explained her that she cannot go home immediately. And next morning, she was willing to go home, and she asked us whether she can go for swimming. So it was a very nice case to stimulate the whole team. The nurses were fascinated by this, and all the nurses and all the staff was supporting us to go in this direction. This is another case showing avascular zone due to occlusion of middle cerebral artery, and here after opening the artery, the brain is again vascularized. So this is the Prac 16 study is actually not a randomized study, it is a registry, it is a prospective registry, and the registry is testing basically two questions. One is feasibility and safety of mechanical catheter-based thrombectomy when it is done in cardiology department. And second question is whether it is safe and effective when it is done without thrombolysis. So we use thrombolysis in some patients. We leave the decision on our neurologists. And the more we do these procedures, the more neurologists indicate patients just without thrombolysis. It depends, of course, on the time. So this is the routine, how the patient is coming to us. So emergency medical service is calling us that the patient with possible stroke is somewhere. And when the emergency medical service is calling us to a stroke phone, there is a special stroke phone which is served by neurologists. So then the neurologist is alarming us already as a preliminary call that there may be a case for intervention. So if we are somewhere at the middle of the night, so we can be preparing to go to the hospital, and then we are waiting for second call, which comes after CT angiography, and when CT angiography confirms the indication, then we go and we do the procedure. And after the procedure, the patient goes for a few hours to cardiac ICU and then goes through CT control to neurology ICU. So basically, we do this as a service for our neurology department. These are the data, the results of the study. I think I have more slide. No, I don't have the slide here. So this data basically show that in all patients we have 40% success rate to restore the neurologic function. All these patients are major strokes. This is a method which is used only for moderate or major strokes. The NIHSS score, which we use as a stratification for this procedure, is 6. So all these strokes are NIHSS score above 6. So this means moderate to severe strokes. And the data are almost identical to the data from international randomized trials testing this method. This is a slide from a recent publication in European Stroke Journal, and this is very sad. These are very sad data, because mechanical thrombectomy is, since 2015, recognized as Class 1 indication. So when it is Class 1A indication, this means that it should be offered to all patients who are suitable by indication for this procedure. But this map shows you that it is not, there is not a single country where it is sufficiently performed. The more blue, the more procedures are done. So basically, leading countries are Germany and Czech Republic here. And then less blue means slightly less, and when it is red, there is almost nothing done. And better picture gives you this slide, because this slide is based on the data from this trial. This is not a trial, this is a European survey organized by European Stroke Organization. But this slide combines the data from that survey with data from UK, where it was studied by McMeekin and colleagues, and they found that from United Kingdom stroke patients, approximately 16% of patients with ischemic stroke require this procedure or would be theoretically indicated for this procedure. So then I prepared this slide and showing that per 1,000 ischemic strokes, ideally 160 patients should undergo this procedure. And the reality in Europe is this. So even the best countries are about 1/3 of the real need of patients. So this is a horrible situation. And very rich countries like United Kingdom are somewhere here. So it is very, very bad. So this means that we have the method, which can be used to help the patient, but the method is not used. And why it is? It is not because the countries are not rich, because UK is a rich country. It is not a matter of money. It is a matter of lack of the staff. There are not enough trained staff to perform this procedure. Prac 18 study is another study which was published recently, and this is a study which compared ticagrelor and prasugrel, two potent antiplatelet drugs, in the setting of acute myocardial infarction. And these drugs were each individually, each separately was proved to be effective, but they were never compared head-to-head to each other. So we did this comparative trial, and it was published in Circulation, and it showed that both drugs are equally effective. Prac 19 study is a study which was recently completed, and it tested bioresorbable vascular scaffolds, so bioresorbable stents. And this is a picture of intravascular OCT, optical coherence tomography. And here you see the stent struts after implantation, and then after 1 year. And this is a CT scan showing that these stents have only the markers, but the stent is here and doesn't interfere with CT imaging, of course, while metallic stent, of course, interferes with CT imaging. And the data were published again in Circulation Interventions. As I said, we have now several ongoing trials, and I listed them here. So Prac 17 is still ongoing, and then 4 new trials are here. And I think from these ongoing trials, the Prac 17 will be the most interesting because it is testing left atrial appendage occlusion. And we published the design of the study in the European Heart Journal, and the study will finish next year. The study basically is comparing left atrial appendage occlusion done by through catheter with modern novel oral anticoagulant apixaban. So one arm in the study receives left atrial appendage occluder, and the other arm receives apixaban long-term treatment. As was said in the introduction, we received this award from the WHO for treatment of myocardial infarction in the country. And I'm coming now to the end. And as I said, last years we are more and more involved in acute stroke, and we propose that in future cardiology and neurology should come together, and there will be probably some kind of merge, cardioneurology or neurocardiology, whatever we can call it. And it is not only about stroke, because acute stroke is a disease where the origin is in the heart, but the consequence is in the brain. But we have also Takotsubo syndrome, where the problem is in the brain, and the end is in the heart. So there are many things where we can work together, neurologists and cardiologists, and even psychiatrists, because Takotsubo is also in some psychiatric patients possible. And I show you at the end one of our best cases, which I call a showcase for neurocardiology, because this was a patient in whom we did in few days several invasive procedures with fantastic result. This gentleman is 70 years old, and he came in 3:30 in the morning, so in the middle of the night, to our department with acute bilateral leg ischemia. So he had terrible pain in both legs, and he had occlusion of both femoral arteries. Dr. Rohac, a colleague of us, did perfect intervention during the night. He opened both femoral arteries, stented them with very nice result, and in the morning patient was okay without any problem, and everything was fine. But 18 hours later, the patient suffered acute stroke, acute ischemic stroke, severe acute ischemic stroke with occlusion of middle cerebral artery. This is avascular zone of the brain. Here you may see the distal catheter introduced to the lesion. And here we do, this is routine, what we do during the procedure. We first push the catheter through the clot, and then we inject a small amount of contrast distally to verify that we are intraluminally. And this is the intraluminal injection, so you see the distal vessels. So this means that we are safe for the patient, and then we can start to work with thrombectomy device. And after removal of the clot, you see normal vascularization of the brain, so the blood flow is restored again. This because the patient suffered the stroke while being in the hospital, so this procedure was done almost immediately. So again, this patient recovered very nicely immediately during the procedure and was doing fine and was quite happy. But of course, when we have seen 2 obliterations in the legs and now 1 in the brain, there was clear that there must be something behind it. So then we did transesophageal echo, and there is open foramen ovale with some bilateral shunting. But why is there open foramen ovale? Normally it is not open. It is opened when there is increased pressure in the right heart. So then we looked at his pulmonary arteries, and we found pulmonary embolism as the real cause. So the story basically started with silent deep venous thrombosis, then mid-size pulmonary embolism, which was not reported by the patient to anybody, so this probably happened a few days before the acute leg ischemia, and then paradoxical emboli to legs and to the brain. So of course, we treated with anticoagulation. It was improved, and before discharge, we closed his foramen ovale by occluder. So he went home after 6 days, completely asymptomatic, and we were presenting this case in television, in Czech television, to advertise also not only our center, but all these methods which were done in one patient during a few days. So when I am speaking about neurocardiology or cardioneurology, I like this reference to Professor Spengos from Greece. He is a neurologist, and he said, we should work closely together. While neurologists are thinkers, cardiologists are doers. And combination of both will be of great help to stroke patients. And this is the picture showing which all specialties should work together. We should not fight against each other, but we should work together for the benefit of our patients. And my last slide, we should work together not only in medicine. Thank you very much.
Thank you very much for this very impressive and very inspiring talk. Actually, it was also very inspiring for me because it was a very good example that scientific observations can be translated into clinical practice, and also by very well-designed clinical trials, your results were raised into guidelines. So it's really impressive. Thank you very much. And now I invite Professor Béla Merkely, Rector of the Semmelweis University, to present our highest scientific award to you as a recognition of your scientific achievements.
So, dear Professor Petr Widimský, dear Petr, I am honored and glad to present you today the Semmelweis Budapest Award. Congratulations. Just come closer. And this is a nice silver medal with a very nice figure of Ignaz Semmelweis.
Thank you.
Thank you. Congratulations.
Once more, I would like to thank you for this award, which is a real exceptional honor for me. And also I would like to thank to all Hungarian cardiologists with whom I have very close relations for many years, and I see some of them here. And I have also a long cooperation with Professor Merkely. We published a couple of papers together, and I hope this cooperation will be even improved and deepened in future. Thank you.
Thank you. Thank you very much. Thank you very much for joining us.
Yes, thank you very much. And just as a remark, let me congratulate you as well on behalf of the whole community of Semmelweis University. And we wish you a good health and also future collaborations together with the V4. Thank you very much.
Thank you.
And thanks for the audience.